You're listening to Wayne Buckler on Health Professional Radio. Recently I spoke with CEO of the Rural Health Alliance, Gordon Gregory, who told us about the organisation and its part in the Australian health system, and that interview is available on our archive for people who may have missed it. I invited Gordon back to tell us about the policy and lobbying work of the Rural Health Alliance, and he's joined us today. Gordon, welcome back to Health Professional Radio.
Lovely to talk to you again, Wayne. Thanks a lot.
Now, tell me, apart from rounding up 37 organisations into one coherent perspective on policy issues, what are the issues that you've been working on that would resonate with the audience now?
Yeah, interesting question. I mean, there's a mix, Wayne. We've been around for about 20 years, and in some of there are a number of issues which, as you would imagine, have always been with us. I mean, there is one very obvious one, is there not, and that is the state of Aboriginal and Torres Strait Islander health. I mean, I think people are aware that this is, not only a national shame, the fact that we haven't been able to do as well as for the Indigenous populations in this country as they've done in New Zealand or Canada or America. So it's not only a national shame, it is probably one of the social policy areas which actually brings us some international shame. So you can imagine, and your listeners can imagine, I'm sure, that we have always been concerned with the state of Aboriginal and Torres Strait Islander health. The life expectancy at birth, as people know, is between 10 and 13 years, depending on who you ask and how you measure it, lower for the first Australians than it is for non-Indigenous Australians. So this is a horrible thing to have to admit. However, of course, we're not exclusively, we're not even strongly an Indigenous organisation. Of the 37 member bodies you mentioned we have, only 3 are Indigenous. They are National Aboriginal Community Controlled Health Organisation, the Australian Indigenous Doctors Association, and Indigenous Allied Health Australia. Now, they're 3 wonderful, energetic, busy organisations which obviously we look to for leadership, but we are quintessentially white, if you like, in the sense that, we hold teleconferences. We expect people to be able to contribute to teleconferences where there are 30 or 40 people on, which is quite an ask for people who might be shy or whatever. So what I'm saying is we are a white organisation. I don't apologise for that at all. We are led and directed in our work on Indigenous health by 3 wonderful Indigenous organisations, and we do what we can. We are faithful. We are loyal to the cause. So we never miss an opportunity to say to governments and oppositions of the day, we really must do better. And of course, those are only a few words, but we've got some views about. I won't go into them now, but we've got some views about how we can do better. And of course, this goes to the very broad basis of the problems, the challenges, the unmet needs in relation to Aboriginal and Torres Strait Islander health and well-being. So that's one issue with which we are still constantly busy, and the hope is that one day soon it'll not be a priority because it's all fixed. That's our long-term aim, as with everybody else's. Other issues in that sort of category, that is those that have always been with us, I guess the first to mention is workforce. It's long been the case, and sadly still is the case, that the workforce distribution in Australia, I'm talking about health workforce, is crook. We do not have our fair share of doctors, nurses, specialists, allied health professionals, dentists, pharmacies, managers, and so on. So we've got a lot of organisations which are closely involved in this, immediately involved, because they are actually professional organisations. So we've got, among our 37 members, as you remember from the previous bit we did to air, we've got professional groups like the doctors, like the remote area nurses, the rural nurses, the psychologists, the physiotherapists, the allied health professionals, the pharmacists, and so on. So all these have got a very special interest because it's their profession. So we've been working away for years and years and years, and have had all sorts of policy proposals for what you would call improving the distribution of the health workforce. You can hear me saying, Wayne, improving the distribution, because it is the case that for some professions, we've got enough in Australia. I mean, some people would actually argue we've got enough doctors, but the problem is their distribution. We've got too many of them in the major cities. And also some people would point out that we've got enough pharmacists and even dentists. I mean, dentists in remote areas, no pun intended, are scarce as hen's teeth. But we've got a lot of dentists who are living and working, or living and not working as dentists, in capital cities. So this is a second issue then. Workforce distribution is a second issue with which we have long been concerned and still are, because we still haven't got it right. We as a nation still haven't got it right. Thirdly, there's a small number of policy issues relating to population health groups. So I'm going to mention really only two, I think. I'm going to mention mental health and dental, oral or dental health, because in both cases, well, let's talk about mental health first. Mental health is actually not more prevalent in rural areas than the cities, but its impacts are worse for obvious reasons, because there are fewer specialist staff around. The mental health nurses are not there, poor access to psychologists, busy GPs, and so on. So mental health consequences, or mental illness consequences in rural areas, are greater than cities. So this is a particular challenge to us, which we've been working on, along with our colleagues, with Mental Health Australia and others, because we're an organisation that loves to collaborate with other organisations to do good work, and we do that whenever we can. So that's for mental health. Now, for oral and dental health, as I've said, the distribution of dentists is even worse than the distribution of doctors. And yet we're not quite so well aware of this. The Commonwealth government, the previous government, in fact, promised to put significant amounts of additional money into public dental health services, which could outreach to rural areas and help with the waiting list and so on. So, this is one area where we are concerned. For instance, in the coming budget in May, the federal budget, we would like to see the Commonwealth government reverse the postponement of the significant new funding for public dental health services, which was promised by the previous government. In the current fiscal environment, this is, I guess, unlikely, but nevertheless, if it doesn't happen, then we will still have the situation in which serious diseases by oral and dental health problems, which are entirely preventable, are affecting people's comfort, affecting people's ability to eat well, affecting people's ability to get a job, and affecting the intake, the people who go to hospital for oral and dental health emergencies. You would be surprised, or perhaps not, at the proportion of people who enter emergency departments of hospitals because of an oral or dental emergency. So there's two, and so what I've listed so far, and I'm sorry I'm talking perhaps too quickly, I hope you can understand me. So there's a range of issues which are ongoing, and I've mentioned a couple of them. And then the second class, and with this I'll end, are the opportunistic ones. So for instance, there is a government inquiry, there's a Senate inquiry into speech pathology services, as there was 6 months ago. There's a Senate inquiry into out-of-pocket costs, which of course is very much flavour of the month in terms of the debate about whether there should be co-payments. So this is a second set of issues which from time to time become a priority for us, because they're important for rural and remote people, and because there's an opportunity to do something created by a government inquiry or something which has just cropped up.
Yes, and you try and take advantage of those at the time.
That's right. We will write a submission. So the process in which I outlined briefly in our first chat, that is, so there will be an inquiry into speech pathology, say, and this is a real example of something that happened six months ago or so. Our council will say, yes, there are particular issues relating to speech pathology in rural areas, probably because we don't have enough speech pathologists, and it's very hard to access this more specialized type of service. Therefore, council agrees that we should make a submission. The job of the staff here is to draft such a submission. So obviously we then go out and we seek evidence. It's got to be evidence-based. So we seek the data, and we seek evidence from people who know. So obviously we'll talk to speech pathologists. We'll talk to patients who are in need of speech pathology services. We draft a submission, and then it goes to council, and it'll knock back and forth until council say, yeah, this is right. And I should add, of course, that with 37 member bodies, we never get 37 tick. So we have to work to the presumption that if we don't hear from a particular body, then we assume agreement. So, most organizations will get back, but many will say, well, that's fine, and they won't have the time or the opportunity to get back. So we have a strict protocol that if we don't hear from the members of council who represent their body on council, then we have to assume agreement. So we proceed. We then make the submission to the Senate inquiry or whatever it is. We then hope, of course, for the opportunity to provide evidence at a public hearing, and we often do. We often get, because of the the number of bodies we pull together. You know, we often get invited to actually deliver evidence at a public hearing of these inquiries. We say it as it is. We represent the rural voice. We make sure they're at the table. And then, of course, the committee of inquiry, the secretary will do its thing, and then there'll be a report. So then we'll look in the report and we'll say, okay, these are the recommendations they've made, and we will then promote to governments and anybody else in a position to act on them. Those are the recommendations from that report which suit rural people.
A fascinating and very essential pursuit, I think, Gordon. And can I say thank you for articulating it so plainly and clearly for us today. Unfortunately, we're right out of time. You've been listening to Wayne Buckler on Health Professional Radio, and I've been in conversation with Gordon Gregory, the CEO of the Rural Health Alliance. This conversation is on our archive as both a transcript and an audio file. For those of you who are seeking more information, I do urge you to go to www.ruralhealth.org.au for an insight into the policy perspectives as they affect rural health in Australia. Gordon, it's been a pleasure having you on the radio. I look forward to talking to you again.
That'd be great, Wayne. Anytime you'd like another chat, I'll be very pleased to do so.
I'm sure our listeners would love to hear more from you.
Thanks so much.
This is Wayne Buckler on Health Professional Radio.